Let's dive straight into this explainer on Step 2 CK Neurology Decision Logic. We're keeping this highly focused on exactly what you need to know: pattern recognition, mechanisms, chronologies, and clinical presentations. Section 1. Language localization and aphasia syndromes. Let's get to it. The name of the game here is pattern recognition. So with Broca's aphasia, you're going to see a patient with sparse, non-fluent, and really effortful speech. Now, their comprehension is relatively preserved, but repetition, that's impaired. Because this usually stems from a dominant inferior frontal injury, you'll frequently see it paired with a right hemiparesis, specifically weakness in the face and upper limb. Now, Wernicke aphasias is a different story. These patients have very fluent, voluminous speech, but it's ultimately meaningless. They've got impaired comprehension and impaired repetition, usually due to a dominant posterior superior temporal injury. A huge clue to look out for is an associated right superior visual field defect. Finally, let's look at conduction aphasia. Here, speech is fluent, maybe a few phonemic errors, and comprehension is completely preserved, but their repetition is very poor. This is your classic arcuate fasciculus injury, where the receptive and expressive language centers basically get disconnected. Moving right along to Section 2, idiopathic intracranial hypertension, also known as pseudotumor cerebri. On test day, the classic patient demographic you're going to see is a woman of childbearing age who has obesity or recent weight gain. You've got to pay close attention to medication triggers here. The big culprits are retinoids, vitamin A, tetracyclines, and growth hormone. So what's actually happening? The underlying mechanism is impaired cerebral spinal fluid resorption, paired with intracranial venous hypertension. Clinically, these patients are going to complain of a diffuse headache, maybe some nausea, and notably, visual changes. We're talking transient visual obscurations, an enlarged blind spot, and diplopia. That diplopia is specifically due to an abducens nerve or cranial nerve 6 palsy. You might also catch them mentioning pulsatile tinnitus or even retrobulbar neck or back pain. Now, the evaluation sequence here is absolutely strict. You cannot just jump straight to a lumbar puncture. First up, you do a thorough clinical and visual assessment. That means checking visual acuity, visual fields, and doing a fundoscopy to look for papilledema. If you do see papilledema, you must get an urgent CT or MRI. You have to definitively rule out mass lesions or obstructive hydrocephalus first. And if there's any clinical concern for a cerebral venous sinus thrombosis, you need to add an MR venography. Only after the imaging clears them can you safely perform that lumbar puncture. The diagnostic finding you're looking for is an elevated opening pressure that's greater than 250 millimeters of water in obese patients, with absolutely zero signs of infection in the CSF. When it comes to management, it hinges entirely on their visual function. For every single patient, weight loss counseling is paramount. Now, if there's no immediate threat to their vision, you can just start a carbonic anhydrase inhibitor like acetazolamide or topiramate to control the symptoms. But if their vision is threatened or rapidly declining, that's an emergency. You've got to bridge them immediately with serial, repeat lumbar punctures or a temporizing lumbar drain. This buys you time and serves as a vital bridge to definitive surgical intervention, which will be either a CSF shunt or an optic nerve sheath fenestration to literally save their sight. All right, Section 3, normal pressure hydrocephalus. The exact sequence of symptom onset here is a classic exam pattern you need to know cold. Gait instability always appears first. We're talking about a wide-base gait with frequent falls. This is then followed by cognitive dysfunction and finally urinary urgency or incontinence. Listen, if the cognitive issues or the incontinence happen before the gait issues, you need to reconsider the diagnosis of NPH entirely. When you're evaluating these patients, a brain MRI is going to show ventricles that are enlarged way out of proportion to the underlying brain atrophy. But the definitive diagnostic step, which also happens to predict treatment success, is the Miller-Fisher test. Basically, a large volume lumbar tap. If you remove that spinal fluid and see a marked clinical improvement in their gait right after, that perfectly predicts they'll have a positive, lasting response to a ventricular peritoneal shunt. Section 4, primary headache patterns. Let's break these down. When you're differentiating these on the exam, remember that migraines are classically pulsatile or throbbing. They're often unilateral, last anywhere from 4 to 72 hours, and usually come with auras, photophobia, phonophobia, and nausea. Tension headaches, by contrast, present as a bilateral, steady, band-like pressure. They're dull, they're tight, and they're persistent, but without all those severe autonomic or neurosensory symptoms. Then you have cluster headaches, which are an entirely different beast. These cause excruciating, sharp, severe, unilateral, orbital, supraorbital, or temporal pain. They're much shorter, lasting 15 to 90 minutes, often hit during sleep, and are accompanied by ipsilateral autonomic features. So think sweating, facial flushing, nasal congestion, lacrimation, and just this intense physical restlessness.
There are two really vital exceptions and patterns to keep in mind here. First, pediatric migraines. They don't always follow the adult rules. They can be notably shorter in duration and are uniquely bifrontal rather than unilateral. Second, we have medication overuse headaches. These pop up when a patient has frequent headaches and tries to fix it with frequent use of acute abortive medications. The most common culprit drugs are butalbital-containing products, acetaminophen, and opioids. The management strategy here is definitive. You absolutely require immediate cessation of the culprit drug, and you usually pair that with the initiation of a dedicated preventative therapy.
Drilling down into cluster headaches for a second, the treatment is highly specific. For acute abortive treatment, you demand 100% oxygen at 6 to 12 liters per minute for about 15 minutes, or you give a subcutaneous injection of sumatriptan. Preventative management is crucial because these headaches occur in daily clusters over several weeks. For that, you're going to rely heavily on calcium channel blockers like verapamil, or alternatively, lithium or tarpyramate.
Okay, moving to Section 5, managing raised intracranial pressure.
Your clinical red flags for raised ICP include a headache that characteristically gets worse in the morning, or while they're lying supine throughout the night, or during maneuvers that naturally increase pressure, like the Valsalva maneuver, coughing, or just leaning forward. You're also going to see vomiting, mental status changes, transient bilateral vision loss that varies based on their head position, and an enlarged physiologic blind spot. And remember, the Cushing triad, which is hypertension, bradycardia, and irregular respirations, is a very poor prognostic sign. It tells you cerebral herniation is imminent. The treatment targets here are based exactly on the Monroe-Kelly doctrine. If you need to extract brain water and reduce parenchymal volume, you use osmotic therapy like hypertonic saline or mannitol. To decrease cerebral blood volume, you've got a few options. Elevate the head of the bed to increase venous outflow, use sedation to lower the brain's metabolic demand, or use brief hyperventilation to decrease PaCO2. That last one causes rapid vasoconstriction. Keep in mind, hyperventilation is the fastest way to drop ICP, but it is strictly a temporary bridge. To decrease CSF volume, you'd use an external ventricular drain. And finally, if you need to actually increase the cranial volume itself, a decompressive craniectomy is performed. Finally, Section 6, Thunderclap Headache Evaluation. This strict diagnostic criterion for a thunderclap headache is sudden and severe pain that reaches its absolute maximum intensity within 60 minutes. Often, patients will describe it as reaching peak intensity almost instantly, quite literally, like being struck by lightning. Now, a ruptured aneurysm causing a subarachnoid hemorrhage, along with reversible cerebral vasoconstriction syndrome, or RCVS, are your most common culprits. But your differential absolutely must remain broad here. You have to consider pituitary apoplexy, especially if you're seeing visual field defects and ophthalmoplegia. You also need to think about cervical artery dissection if there's accompanying posterior neck pain. And don't forget cavernous sinus thrombosis, meningitis, and posterior reversible encephalopathy syndrome, or PRES, particularly if the patient is in the middle of a severe hypertensive crisis. Because this differential is full of immediately life-threatening conditions, the emergency evaluation sequence is non-negotiable. It dictates an immediate non-contrast head CT to look for acute blood in the subarachnoid space. If that CT is totally negative but your clinical suspicion is still high, you are mandated to follow up with a lumbar puncture to check for xanthocronia or an expedited MRI of the head to rule out further structural and vascular causes. And that's it. Recognizing these strict patterns and sequencing is exactly what you need for mastering neurology decision logic.